Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with John. How are you doing today?
I'm doing well. Thanks for having me on the show.
Awesome. So I have you on the podcast specifically talking about needle decompression and confirmation of placement. But since this is the first time on the podcast, would you mind doing just a quick introduction of yourself?
Yeah, absolutely. I'm John Aho. I practice general surgery and emergency general surgery at Sanford Health in South Dakota. And I also run a medical device company focused on improving outcomes in tension pneumothorax. You may have heard of it. It's called the CapNoSpot. Our company's numeric. We spun it out of Mayo Clinic in Rochester when we were working on research for tension pneumothorax, essentially. Some of our work has already changed ATLS guidelines, longer needles, fatter catheters, and alternative placement locations. And this was a subsequent step to that in terms of improving tension pneumothorax outcomes that we'd been working on for probably the past 7 or 8 years now. Is what it took to get it from basically a research idea on a napkin to an actual device company that's selling around the world. I never thought I'd be, involved in anything like that. But yeah, it's been an absolute honor to make people a little bit better.
Nice. Well, perfect. So I guess just starting off, one thing I found that's been particularly difficult when it comes to especially pneumothoraces, developing into tension pneumothoraces, is just confirming or denying somebody actually needs a procedure done, just period. So just from your experience, training, etc., how a patient comes in, how do you get to the point where I need to decompress?
So that's a really hard question. So I would look at mechanism of injury. If it's penetrating injury to the chest, that makes my differential for tension or other parenchymal injury to the lung or tracheobronchial tree much higher. Blunt trauma is a lot more complicated. I think if they have bony deformity to the chest, their ribs have essentially turned into a penetrating object, potentially, that has punctured the lung. And there's also a non-trivial number of people that have pulmonary blebs, or just that pressure is enough to cause injury to the lung parenchyma and disrupt it, eventually causing a tension pneumothorax. Those take a little bit longer, I think, in my observation to develop. But and then assessment. If you're very suspicious, or you're even a little bit suspicious, keep an eye on it. Make sure that their respiratory status is in fact worsening, that you think that their lung sounds are getting more distant. Tracheal deviation, I know that's on the list that people talk about. I have maybe seen something like that once ever. I think tracheal deviation is a very late sign if it's present at all. And that's especially hard to assess, when somebody's supine and maybe their head's tilted just a little bit. It's hard to get an idea for sure if that's even a thing. I think if they have diminished breath sounds, they have a mechanism that fits, they have bony instability to the chest wall or penetrating into the injury to the chest, those are people that I'd be very suspicious of. Other ones, I would just keep an eye on in terms of, is their respiratory status worsening? Are they getting more tachypnic? Is their blood pressure getting worse? Do they have developing or worsening evidence of tension pneumothorax, despite not having immediate signs of it? It's not an immediate thing that gets developed. Imagine a trickle of air coming from the lung in some patients. It's not a giant hole in their lung often. And so in those patients, constantly be assessing and reassessing and monitoring and paying attention to the numbers. Those are the only objective thing you have. But if the story fits, I would probably go ahead and decompress with whatever local agency protocols are, or whatever you have that's available or appropriate for your clinical situation.
Sure. So you mentioned, tracheal deviation. I also agree. It's like super late, and thus far I have not seen it, thankfully.
Right, but we'll just say a quiet prayer for you.
What about things like unilateral rise and fall, or
Yeah, so in the penetrating injury situation, I have seen that a little bit. You can sometimes see that paradoxical chest motion if it's observed with a blunt and a flail injury. I think there's more flail injury pneumothorax combinations than I think we appreciate, just because the ribs are quite sharp when they're broken. The like a true unilateral absence of movement, I think, is not correct. I would say it's more of a slightly diminished, and you have to be really in tune to catch something like that. I don't think it's as common as they say in the books. If you have chest rise to one side, everything's connected. Like, you're going to have a little bit on the other side. I would never say it's absence of chest wall, but it might be what I'll call marginally diminished chest motion on the other side. I wouldn't put too much stock in the symmetry, but I would put a decent amount. And if they have real deal absence of breath sounds on one side, I would be very suspicious. But same thing as with the chest wall motion. You can hear those sounds transmitted across too. You may have a slightly diminished finding of slightly reduced breath sounds or slightly diminished breath sounds, but I've never, with the exception of maybe some really big hemothoraces or really, really big pneumothoraces, you may not have a true absence of breath sounds either.
Yeah. Sub-Q emphysema is especially something that keeps getting brought up. I've yet to just appreciate that either. Is that something that takes like a really long time to develop, or could I use that as an indicator?
So sub-Q emphysema, it literally feels like Rice Krispies or like marbles underneath the skin. It's the first time you feel it, it's truly bizarre. That I have seen in combination with what I'll call musculoskeletal trauma to the chest wall. Now that's just air tracking through the soft tissue planes along the mediastinum or along the pleural surfaces and getting into the subcutaneous space somehow. Mm-hmm. If it's quick and they have subcutaneous emphysema, as in like on the order of minutes, you're talking about a major disruption to the tracheobronchial tree. You're not talking, there's a little parenchymal injury on the periphery of the right upper lobe of the lung. That's going to be something that is going to take time to develop subcutaneous emphysema. That's and it can happen with parenchymal, lung injury, but it's something that'll take a little bit longer to develop. But it can get really, really bad, especially if you have big or moderate sized airway trauma. Mm-hmm. You can see that happen pretty quick, and it can be pretty dramatic too. Like their face look like they have angioedema, but it's just air. Okay. Their eyes are basically can't even open their eyes because there's so much air within their eyelids and stuff too. So it can be pretty dramatic when it happens. Now, in those I don't think I've ever seen a tension pneumothorax with subcutaneous emphysema. I've seen plenty of pneumothoraxes with subcutaneous emphysema, but and I think part of the reason that might be the case is because if you do have a disruption to the chest wall, the air has somewhere to go. Mm-hmm. And it's dissecting through those tissues relatively easily. I don't think I've seen a tension with sub-Q emphysema, but I've definitely seen sub-Q emphysema with like larger airway or medium, small size airway disruptions for sure. Okay,
awesome. So we're leaning towards this patient, needs some kind of needle D, a finger Thor, or something. They need something to happen. What kind of sites do you pick? You pick one over the other? Do you have a favorite, and why?
So I would say it depends on clinical conditions, right? If they're in the back of a helicopter and they are strapped to a backboard and their arms are at their side, you're not going to be able to get at that lateral position very well. So there are two main positions that I would consider. There are other options, but we're not going to go into that. So second intercostal space, midclavicular line, sternal angle of Louis. Okay, most people could find the sternal angle of Louis relatively reliably. An area that I think is commonly not done properly is what I'll call the midclavicular line. The clavicle goes way out to the edge of your shoulder. It is not, right here. So if you're drawing a midclavicular line and you meet that second intercostal space and somehow you're medial to the nipple, you're wrong somehow. And almost always it's that midclavicular line. There's this thing in trauma surgery called trauma box. It's medial to the nipples, xiphoid down or up to sternal notch. You should not be putting a large penetrating object within the trauma box. That shouldn't happen. It needs to be lateral to the nipple, which is the true midclavicular line and sternal angle of Louis. And the other thing is either being perpendicular or angling in just a little bit. There is curvature to the chest wall, and we're not, block people made out of cubes. So the chest wall has a lot more curvature to it than people think. But getting that true lateral or at the midclavicular line and always being lateral to the nipple, I think is key. Getting second versus third intercostal space, not as big of a deal. But it cannot be, below the nipple or medial to the nipple for sure. It needs to be at the second intercostal space, midclavicular line. And then the alternative location, there's anterior, mid, and posterior axillary line. Good mid-axillary line, I think, is a great option if you don't have their arms strapped to their sides of their body and you have the mobility of their arm. That's the standard recommended position now. The most common error I see for placements of needles in those spaces is going too low. You need to be almost right below the axillary hairline. Like you go too much lower than that, you risk going through the lung, through the diaphragm and into the liver. The diaphragm goes up much higher than people think it does at end expiration. So it can go almost all the way up to the level of your nipples at end expiration. And so at that point, you have very marginal little triangle to actually get that needle into the correct depth. So, but way up here, you've got a lot more wiggle room in terms of depth and getting it to the correct location. So those would be the two things with placement location. Placement depth, almost always under insertion is common. If you think about how thick a set of pork ribs are, that's basically how thick your ribs are in terms of, intercostal musculature and ribs. That's about 2 centimeters. You add sub-Q of varying thickness, for different people. Your average chest wall is probably about 4 or 5 centimeters thick on the average in both locations. There's marginal differences. Yeah, they're a little thicker anteriorly on the average, but you have a young military-aged person who lifts, they're going to be much thicker because you have to go through pec major up here. They're probably going to be thinner in that lateral position. Now you get somebody who's obese and doesn't lift, who has a lot of what I'll call axillary fat. They may very well be thicker in that position. So I personally think both positions are equivalent, but there are limitations to both. And a lot of them are based on how easy is it to get at that position. For most stuff, most people are supine. They're going to be secured to a backboard with their arms at their sides. I tend to favor the anterior position. The other thing is it stays out of the way for their eventual chest tube. And I think during transport and a lot of jostling around, that lateral position is at risk for getting kink twisted or obstructed from just catheter patient interactions of their arm against the catheter. Sure.
And probably the hardest part, especially when you talk about decompression, is actually confirming you got it into the right place. I mean, finger Thor, super easy. If you feel lung, you made it. Chest tube, if it goes in, like you feel the lung and you've you can feel with your finger that chest tube sliding in, you made it. Needle decompression, though, it's really hard. I generally work in relatively noisy places. I have yet to hear it like a true like whoosh of air that everybody tells me is going to happen. So, like, how do I even know that I've put the needle in the right spot?
I think I've heard the gush of air maybe once or twice in a relatively quiet spot for somebody who truly has attention. Now, there's the number of needle Ds, or honestly, even other decompression maneuvers that I've done and actually heard the gush of air compared to the number of times I've heard it. I don't think it would be controversial to say that the gush of air is a lie. And the other thing is the gush of air depends on what's that pressure gradient between the tension and the atmosphere, and how fat is the catheter. We've gotten, progressively larger diameter catheters over time. I don't think I wouldn't be shocked if with, say, a 20 gauge angiocatheter that the sound is easier to hear than with a 14 or a 10 or a 16. But I don't think it would be mega controversial to say that the gush of air on the average is a lie. So how do you confirm it? Well, okay, you can monitor vital signs. Those will change over the order of a few minutes, but you've already done your intervention and you may need to do something else. And, continuously checking and crossing your fingers that the vital signs are going to change when you didn't hear the gush of air. I think that's being hopeful. One thing that people have tried to jerry rig along the way is dumping half of a saline flush out and trying to aspirate it. Okay, well, that's great if you know what the resistance of the needles or the catheter is supposed to feel like. You know what kinked feels like, and you know what unkinked feels like. But you can leak air through the connector. You can, if you pull too much vacuum too hard on that saline, it'll cavitate and it'll boil, and you may think that you have air. But if you're going to do that, you need to practice and know what that sense of aspirating really feels like. Another option would be to use a colorimetric indicator, one of which is the CapNoSpot. That'll change color when it encounters CO2. All these pneumothoraces almost have CO2 in them, with the exception of, a really big, bad open pneumothorax. You might get some air mixing that has a little bit less CO2, but they're still going to have parenchymal disruption and have CO2 within it. So CapNoSpot's easy thing to bolt on to the back of an angiocatheter, has a one-way valve on it too that opens quite easily and shuts quite firmly, so prevents a little bit of air ingress. And the data that we're doing on generating on CapNoSpot with some academic and EMS partners, the data is good. We are likely to show that there's going to be a reduction in number of repeat decompressions or need to convert to a finger Thor for most patients. That data is still getting read out and in the process of being analyzed, but it looks pretty good. And it's relatively inexpensive compared to an angiocatheter. So if you're using two angiocatheters when you could have used one CapNoSpot plus one angiocatheter, you're break even. So, I'm biased. I think something objective for EMS to remove a little bit of the fog that you guys are dealing with day to day is beneficial. And customers across the country and many other countries are tending to agree. So it's starting to be adopted pretty well. I think it's going to replace it for ATLS. I think they like having things that are objective and measurable. And I think CapNoSpot provides that, as opposed to, oh yeah, I definitely heard a gush of air on that one. Did you really? Like, is that actually true, or were we basically guessing?
Right. I want to talk about some other vital signs, and then I want to get right back to talking specifically about the CapNoSpot. But, SpO2 as another one, like, hey, we decompress. He's, tension, he has obstructive shock. SpO2 should jump right back up. Rarely have I seen that happen. And I'm just kind of assuming like some kind of resuscitation is underway to get them out of that shock state. But, I'm just thinking of, from your experience, non-invasive SpO2 monitoring. How accurate how how hard or how much should I even consider what it says once we start getting below that 90?
If it's reading 80s to 90s, that's fairly reliable given a bunch of caveats. There are limitations to non-invasive SpO2 monitoring. Are their hands cold? I have yet to meet somebody who has had a trauma and is in a car, even, in any season except the hottest of summers, who isn't cold in their, index finger. So, okay, putting an SpO2 on their index finger, okay, and expecting that to be reliable on the side of the interstate in the rain, not realistic. And I think if it is under perfect conditions, SpO2 is believable if it's in the 80s to 90s. However, most of the time in the pre-hospital environment, you're not using those under ideal conditions. So understanding the limitations of, okay, this patient has blunt trauma. Yes, maybe he does have a tension pneumothorax, and maybe you did treat it completely correctly, but they also probably have bleeding somewhere in some way, shape, or form, or they're volume down, or they're inebriated, or, all kinds of other things that can affect their peripheral, circulation to the very tip of their index finger. So yes, it's to be believed under perfect conditions, but use your overall clinical judgment. Is the patient pink? Are they warm? Is there, if you have the opportunity to measure their temperature, is their core temperature okay? Is using all of your other clinical judgment, and understanding the limitations of the tools that you're using, I think, are key. Great, had a tension pneumothorax, you treated it, it was a win, high fives all around. Okay, yeah, but he's also got bleeding in his belly, so we should probably be resuscitating him with blood, and if not available, with crystalloid, to at least be able to try to get their blood pressure up so they're continuing to perfuse their brain while we're trying to get them to definitive hemorrhage control.
Yeah. Another, I guess, indicator for doing a needle decompression or finger Thor or whatever is we have the MOI. The patient is short of breath. He's breathing very rapidly. He says it's difficult to breathe. I send it. I did a podcast recently, and I'm kind of ashamed of myself. I don't remember the exact number, but it was 20% plus. They had those indicators. Needle decompression was sent. Patient felt better. We get him to hospital. They do all the things. Obviously, they put him in the tube of truth, and they find out that the needle wasn't actually even in the pleural cavity. So, I guess you would think that I should be able to rely on the patient to tell me that he feels better. I guess, what do you think about that stuff?
Yeah, so I think there are more needles that are placed that were temporarily in the pleural space than are in the pleural space 20, 30 minutes later. So part of it is that. Let's say hypothetically that, that needle D went in the pleural space, you decompressed it, great. People are squishy and people move, and there's respiratory motion during transport. There's, vehicle motion. Patient gets moved from cart to bed to bed to cart to bed. And maybe that catheter worked its way out. That's one possibility, is that catheter was in, but worked its way out. The other possibility is, maybe you just gave them a shot of epinephrine by sticking a needle into them and driving their catecholamines up, and that temporized things for a bit of time. But I think that, and the CT scanner, keep in mind too, that's a fixed moment in time. That is a picture that is taken in an instant. And you don't have that in the back of the ambulance when you are putting a needle D in. Otherwise, we would have no missed needle Ds. So I wouldn't be surprised if something happened from the X to the definitive care, somewhere in between. Catheter worked its way out. Patient, the other thing is patients are very squishy, like more than you think they are. And so like there was this phrase from a book called House of God of, you can reach any body cavity with I think it's a 16 gauge catheter. And but it's often more temporary than you think it is. Like, yeah, you can reach it, but what about when you let go of that forward pressure on the tissues? The tissues bounce back. They don't bounce back instantly. They bounce back over the course of, seconds to minutes sometimes.
Yeah.
And the every time they're taking a breath, their ribs are doing this. So maybe it worked its way out. I'd give them the benefit of the doubt, even if the CT scanner doesn't, show that they, have the needle, in the middle of the pneumothorax on the cross-sectional imaging. But yeah, there's all kinds of shenanigans that could just go on with these things.
Yeah. What about things like ultrasound? Including that.
Yeah, that's a great option. There are a lot of technologies that are currently used in the hospital that could be translated to the pre-hospital space very effectively. I'll be honest, I put finger Thor in the same bucket as this of ultrasound would be great if everybody was a radiologist that did ultrasound-based procedures, or an ICU doctor who put ultrasound-based central access in patients. Expecting the same level of training, performance, facile familiarity with the technology, and then not providing that level of training that would be required to bring practitioners to that point, I think is somewhat it's not going to work out the way, like, you can't just put an ultrasound in the back of the ambulance and give somebody a couple hour course on what a pneumothorax looks like, looking for the pleural sliding.
Right.
It needs to be more involved than that. It needs to be more thoughtful, more meticulous. Curriculums need to be standardized. Qualifications need to be standardized, and there needs to be a bar set, and a standard set if you're going to be doing that. I don't see a lot of resources going to the training aspect of it beyond the okay, well, we bought a butterfly for our ambulance. Okay, all right, that's great. Who knows how to use it? Who knows how to read it? Who knows how to interpret those images? And who is confident enough in that skill set to actually do interventions based on those interpretation of images? There's a lot of stuff that has to happen to be able to use those tools properly. And yeah, okay, great. The ICU doctor knows how to use it to put a central line in. Does the EMTP on the back of the ambulance in rural, pick your location, have that same skill set and have the same amount of training and the same amount of credentialing to be able to, and I'm not saying that they can't. They can absolutely do it. Like, that is a skill that can be learned. But you need to invest in the training to be able to do that, and not just invest in just the technology and put on a 2-hour course of what that's supposed to look like based on a PowerPoint. That's just not going to work.
Yeah. And I think it's one thing to say, training with an ultrasound and say, this is what a pneumothorax or a tension pneumothorax or a hemothorax, this is what it looks like. See? No lung slide. Great. It's another thing to be at the side of a patient. They're throwing you all the signs that they have a problem. You throw the ultrasound on, and you're pretty sure you see lung slide, and not do the procedure based on what you just saw. That's a different level of skill, I think.
Yeah, and it goes both ways, right? So one of them is you can recognize and the pathology, but recognizing the normal, and there is some gray in between the two, and you recognizing that's a tool that you're using to make decisions, not that is the only thing that you're using to make decisions. Yeah, I don't know if I'm seeing the same amount of training time and effort and investment into that would be required to make it so that that's a standard thing.
Yeah, absolutely. So CapNoSpot, I think it makes absolute sense. You got a big pneumothorax, you throw on a colorimetric device on the back of your needle. If it gets into air, it turns purple.
It goes from blue to yellow. So
Blue to yellow?
same as the colorimetric. It goes from blue purple to yellow when it urine, as in the color of urine.
Right. Okay. Perfect. Now, I mean, that's very simple technology. We've had it for decades and decades with our airway conformation. Just I'm imagining the same kind of, I guess, limitations with that. With the airway was it got wet. There was blood in it, or you wouldn't have vomit in the chest, hopefully, but do those same things kind of apply?
Yeah, so we'll use a hemopneumothorax as an example. This is, not an uncommon scenario that we get with when somebody's using a CapNoSpot. They put it in, it goes from blue to yellow, and then it turns red because it fills up with blood. That's okay. The question here was, did they have a pneumothorax? The answer to that was yes, because it turned yellow. But they also had the hemothorax. But the underlying question here was, did you get that needle into the pleural space?
Yeah.
And the answer was yes. Okay, that's great. Is that catheter going to clog? You bet. Absolutely, that angiocatheter is going to clog. Give it enough time, that blood will clot within the angiocatheter. Is it possible that they're going to need another one? Yeah. But what they really need is, definitive hemorrhage control, whether that's a chest tube because the volume is small, or eventual surgery because they're depending on where the bleeding is coming from and the amount of bleeding, et cetera, a bunch of trauma surgery stuff. But like the fundamental question was answered. Did they have a tension pneumothorax, or did they have a large enough of a hemopneumothorax to trigger the indicator? Yeah, but you didn't have to guess about the gush of air, and that catheter's in the right spot. But now they need additional therapies. So yeah,
Okay.
Will blood meth it up? Absolutely it will. But the air almost always will come first because they're supine, and even if you're doing lateral or anterior, the air is going to be at the top.
Okay. What about just getting it into healthy lung? Will it change color?
It will, but it'll take a little bit more time. So if so we'll use the tension pneumothorax situation first. You put it in the tension pneumothorax, it turns color within a few seconds. If you put it in the lung parenchyma, it will turn color because they're going to develop a pneumothorax over the course of about 10 seconds or so, 10 to 20 seconds, somewhere in that range. We don't have great numbers around that, but we know it changes color. Okay. However, okay, in that situation, they probably didn't have a tension because it didn't turn color right away, because the definition of tension would be that there's positive pressure and it's pushing through the catheter. It should have turned instantly. If it takes that long to develop into or to turn the indicator color, they probably didn't have a real tension. You probably made a pneumothorax, but again, you have a catheter, it's in the right spot, it's functional, and it'll stay turned color if it's still draining. If it goes from yellow back to blue, now you got a problem with the catheter itself.
There are things where somebody has an injury on one side and the pneumothorax or the tension is actually on the other side. So the problem didn't go away. Maybe you just put the catheter in the wrong spot.
Yeah, absolutely. And the trauma is very, very difficult because you have incomplete facts in the pre-hospital environment. Like, is it possible that they have rib fractures on both sides? They have tension pneumothorax on one and a simple pneumothorax on the other, or hemothorax on the other? Absolutely. But using the indicator to know, okay, we have removed catheter not in right spot from the equation. That is, and we know that to your earlier comment, about somewhere between 10 and 40% of these angiocatheters don't go into the pleural space the way that we think they do. We don't know what the real number is, but it's, I don't know, let's just say to your colleagues' earlier comment, let's just say it's 1 in 5. We have now removed that as an issue of catheter not in the pleural space. it won't turn color until it's in CO2 rich environment, whether that's lung parenchyma or a pneumothorax or a tension pneumothorax.
Okay. Kind of, I guess, broader picture. We had talked earlier about, the frequency of needle decompressions and things like that. And I think, one, it's kind of difficult to train to an extent.
Yeah.
I think, at least on my half of the world, we train to the extreme where like everybody has tension pneumothorax within seconds of you standing up. And likewise on the other side, on the civilian side, from what I understand, there is like a million Monday morning quarterbacks that want to question every decision that was made to the standard of their training, to the standard of what tools they have available, not necessarily in the realm of this is what this person had available to make a decision on. A patient is coming to you from the field. Some kind of trauma. The patient, let's say blunt trauma, so we'll make it even grayer.
Sure.
Patient was in pain. They said it was hard to breathe. They were really panicky. They're like I said, in pain. Respiratory rates through the roof. Blood pressure starts coming down. SpO2, like his hands are cold. He came from a cold environment. Like SpO2 was going down. I dropped a needle. I didn't really get much relief. I dropped another needle on the other side. They said they felt better. We got here as quick as we could, and I even remembered to clean the sites before I did it. So, do I go to a morbidity mortality or?
So a properly placed needle decompression, the worst thing you can do is put a hole in the lung. That it provided it's in a proper place location. Yep. You were safe with it. You did all of the correct things. Would I have put a needle in that patient? Probably not, but I wasn't there. So worst case scenario, you gave them an air leak on both sides, and then they're sitting in the hospital with the chest tube for, maybe a few days. But did you overtreat? Yeah, maybe. Maybe they were just anxious. I mean, they were spontaneously ventilating and they were talking to you. Yeah. They probably weren't hypotensive enough to, be obtunded, but, they were scared and they were having trouble breathing. And, you had some signs and symptoms, and you had some findings that would suggest that that person needed to be decompressed. I probably would have observed a little bit longer to see how that played out personally, but I don't think you could be faulted in that scenario for overtreating, because the worst thing that you can do with a properly placed needle angiocatheter is put a hole in the lung. Okay. Is that something that's going to kill the patient? No, not as long as they're properly managed in the hospital and, on a trauma ward with, maybe a chest tube on both sides and maybe a pigtail catheter on both sides. But I'd give some feedback saying, maybe consider observing, a little bit. How sure were you about these things? But I think that there's a lot of critique of how things are being done in the pre-hospital environment by people who weren't there, who end up having, hindsight's always 20/20. Like that's not a fair, way to say, okay, great, I have ultrasound, I have x-rays, I have, CT, but most of the time you don't in that environment. Tachypnic, having trouble breathing, SpO2 not great. Okay, I would maybe see how that is going to play out and get a couple more data points, so you start making a little bit of a line and seeing which way the patient is going, especially in somebody who's awake and spontaneously ventilating otherwise. Now, if they're obtunded, I think, had you had the exact same story but they were obtunded, I would have put a needle in that patient.
Okay. So would that be like, so one thing I like to teach guys when it comes to procedures, it's one thing to know academically what your indicators are. It's another thing to actually draw like a mental line in the sand. If the patient gets below this or has this finding or like fill in the blank, you're going to do it.
Right.
For you, what would be that line in the sand that this person has this, I'm going to do it, period?
I would say if they're having progressive tachypnea, and it's getting progressively worse, and they're having progressive hypotension, that's somebody I would do it on. And we know the physical exam signs aren't great. Tracheal deviation is mostly nonsense. Diminished breath sounds, maybe. Diminished chest wall motion on one side, maybe. But absent breath sounds, nah. Absent chest wall motion, no. Okay, so you've got what I'll call a foggy physical exam. But if they're doing this, they're headed downhill, especially because if they're tensioning, the definition is that they're getting hypotensive.
Yep.
So I would, if somebody that you suspect has pneumothorax or you're suspicious of, they're getting more tachypnic, they're getting more hypotensive, that's somebody I'd needle.
All right. Well, awesome, John. Is there anything you'd like to add about either needle decompression or CapNoSpot?
No, nothing whatsoever. I mean, it's a challenging condition to treat, and it's also a challenging condition to even recognize and get that correct. So asking people to recognize it correctly, with very nebulous and variable presentation, and then asking them to treat it with a suboptimal toolkit, I think is the data out of one thing I will bring up is to your quarterbacking scenario is we do know that people are under treating this, and in terms of patients that need a chest tube once they arrive to the trauma bay because they have signs and symptoms of pneumothorax, those patients do tremendously worse. So pre-hospital decompression does save lives. That data is clear, and we know that we're underdoing it a little bit.
Okay, awesome. Well, I appreciate it, John. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.